জি শুরু করুন।
রেসপেক্টেড ফিজিশিয়ান এন্ড অডিয়েন্স, সবাইকে আজকের এই ইসিজি সেশনে স্বাগতম। আমাদের আজকের ইসিজি সেশনের এটি ৮ম পর্ব। আমাদের আজকের টপিক ইসিজি পুটিং ইট অল টুগেদার। যথারীতি আমাদের মাঝে আজকে স্পিকার হিসেবে উপস্থিত আছেন ডক্টর রফিক আহমেদ। ডক্টর রফিক আহমেদ স্যার কনসালটেন্ট কার্ডিয়াক ইলেকট্রোফিজিওলজিস্ট, মেডিস্টার হার্ট অ্যান্ড ভাস্কুলার ইনস্টিটিউট, বেলটিমোর, ইউএসএ। এবং আমাদের সাথে আজকে চেয়ারপারসন হিসেবে উপস্থিত আছেন প্রফেসর মাহমুদ হাসান স্যার। প্রফেসর মাহমুদ হাসান স্যার এক্স ভাইস চ্যান্সেলর বিএসএমএমইউ এবং এক্স প্রেসিডেন্ট বাংলাদেশ মেডিকেল অ্যাসোসিয়েশন। মূলত প্রফেসর মাহমুদ হাসান স্যারের মাধ্যমেই আমরা রফিক আহমেদ স্যারকে আমাদের এই বিডি ফিজিশিয়ানসের মঞ্চে পেয়েছি। এই জন্য মাহমুদ হাসান স্যারের কাছে আমাদের অসীম কৃতজ্ঞতা। আর রফিক স্যারের কথা তো আর কি বলবো, স্যার যে পরিমাণ আন্তরিকতা নিয়ে, স্যার যে পরিমাণ ভালোবাসা নিয়ে আমাদের সাথে আজকের এই ৮ম সেশনটিতে জয়েন করেছেন তা তুলনাহীন। আমি আজকের এই সেশনটি শুরু করার জন্য আমাদের আজকের চেয়ারপারসন প্রফেসর মাহমুদ হাসান স্যারকে আহ্বান জানাচ্ছি।
ধন্যবাদ এহসানুজ্জামান খান সাহেব। আমি বিডি ফিজিশিয়ানসকে ধন্যবাদ জানাচ্ছি। আজকের শুধু নয়, এই যে সিরিজ অফ লেকচারস আপনারা আয়োজন করেছেন, এই কোভিডের সময় যারা আপনার প্রত্যক্ষভাবে বিভিন্ন ধরনের শিক্ষা সংক্রান্ত কর্মকাণ্ডে যোগ দিতে পারেন না বা আমাদের অর্গানাইজ করা সম্ভব হয় না, সেখানে এই ধরনের আপনার ওয়েব মিডিয়াতে যে শিক্ষামূলক আমরা কর্মকাণ্ড আয়োজন করেছি, এটা আমার মনে হয় বিডি ফিজিশিয়ানসের একটা অন্যতম কৃতিত্ব। এবং ডাক্তার রফিক আহমদ সাহেব সম্পর্কে আপনাদের সঙ্গে আগেও কথা হয়েছে যে উনি মানে মেডিকেল সায়েন্সের প্রত্যেকটা ব্রাঞ্চেই অগ্রগতি হচ্ছে, এটা সত্য। তবে কার্ডিওলজিতে এই অগ্রগতি অত্যন্ত দ্রুত এবং আপনার কি বলা যায় যে এটা মানে অনুমান করাই কঠিন, এবং এত স্পেশালাইজড হয়ে গেছে যে আপনার কার্ডিওলজি স্পেশালাইজেশনের মধ্যে আবার সাব স্পেশালাইজেশন হয়ে গেছে। তো আমাদের ডাক্তার রফিক আহমদ সাহেব অত্যন্ত অ্যাডভান্সড স্পেশালিস্ট এবং উনি অত্যন্ত ব্যস্ত, তা সত্ত্বেও যে আমাদেরকে এইভাবে সিরিজ অফ লেকচারস, আজকে ৮ম লেকচার হচ্ছে, উনি মূল্যবান সময় ব্যয় করে আমাদেরকে দিচ্ছেন। আমরা অত্যন্ত কৃতজ্ঞ এবং আমি মনে করছি, এটা আমি আশা করছি না, আমি শিওর যে ওনার এই লেকচারগুলোর মাধ্যমে আমাদের যে একগুচ্ছ চিকিৎসক এই ইসিজি সম্পর্কে যে অভিজ্ঞতা সঞ্চয় করছেন এবং যে জ্ঞান সঞ্চয় করছেন, এটা আপনাদের মাধ্যমে আবার আপনাদের যারা কনিষ্ঠ চিকিৎসক আছেন তাদের মাধ্যমে তাদের কাছে চলে যাবে, এবং এইভাবে ইসিজিতে আমাদের দেশে একটা আমার মনে হয় যে মানের অনেক উন্নয়ন হবে। তো রফিক আহমদ সাহেব বাংলাদেশের জন্য অনেক কিছু করেছেন, ভবিষ্যতেও আমরা আশা রাখি অনেক কিছু করবেন। আমরা ওনার কাছে কৃতজ্ঞতা প্রকাশ করছি এবং ওনাকে আহ্বান করছি আমাদের এই 8th সেশন শুরু করার জন্য। ধন্যবাদ।
মাহমুদ হাসান স্যার, আপনাকে জানিয়ে রাখি আমাদের আগের 7টি সেশনই অলরেডি ইউটিউবে আছে স্যার। এটাও সবাই যারা লাইভ জয়েন করতে পারছে না তারা স্যার সবাই অলরেডি স্যার এগুলো দেখছে।
Good morning. Assalamu alaikum. This is our series of last lectures, but I hope we will continue with this some kind of interaction for ECG. And there are other ECG series lectures that's going on in another forum, so you can join any of those. So today my job is to recapitulate what we have done so far. Last lecture we did the ECGs that require emergency care. And I'm going to go back to the basics again a little bit. So this is an ECG. You can see, please remember this picture. This picture basically, I mean, you look at it and you say this is a normal ECG. Sure, it's a normal ECG, but we need to look at each component. So we need to look at heart rate. So if I look at this heart rate is 66 beats per minute. And then look at the rhythm. Rhythm is, people will always say regular rhythm. That's true, but we want to know whether it's sinus or not. So it's a regular rhythm and it's sinus rhythm because there is a P wave before each QRS complex. But please remember, the mere presence of P wave does not make a sinus rhythm. P means there is atrial activity. So the P wave is upright in lead 2 AVF and lead 1. That means it's sinus. That means it's coming from the right top corner of the heart. And the PR interval here is about 160 millisecond. QRS duration is 80 millisecond. QT interval, you look at where you can measure it, it's 400 millisecond QT interval. I'm measuring in lead V2 QT interval. And then we look at amplitude of the QRS complex in chest lead. This is it's 0.9 millivolt, means 9 small square. And over here is another 10 small square. So 1.9 millivolt, that's a normal voltage. Anything less than 3.5 is normal. And then we look at the T wave. Is it normal? If the T wave normally will be upright in the leads where the QRS is upright. That means if I look at lead V1, QRS is negative, T is negative. That's normal. That's a general rule. AVR, QRS is negative, T is negative. Likewise, V5, QRS is upright, T is upright. That's a general rule with some exceptions. And then we look at ST segment. Is it isoelectric? If you look at all the leads, lead 1, AVL, 2, 3, AVF, they're isoelectric in V4, V5, V6. But if you look at lead V1, it looks slightly elevated. But that's a normal variant. In lead V2, in lead V2, we can see some elevation of the ST segment. That's not abnormal. And then we look for any pathological Q waves. Is there any Q wave? Like, and it is pathological. Pathological Q wave, there is a definition. If you look at lead AVL, there is a small Q wave, but that's less than 1 box and not very deep. That means it's a physiology, it's not a pathological Q wave. So after I have done all this, my final conclusion will be a normal ECG. So I think when we look at any picture, medical picture, we can just go for the abnormal finding, or we can describe the picture. I think even at my age, I find it convenient to describe it, which makes it complete. I think I would request all of you, when you find an ECG, please try to describe it, rate, rhythm, the intervals, and then the morphology of the complexes. And then you come to the final conclusion. If you keep doing it every time you see an ECG, it will become a habit for you, and you will be able to do it right. And I think that's the way to do it. We're talking about the P wave vector. The P wave comes from the sinus node, and it is up top right corner of the heart, and it goes down. And that's why 2, 3, and AVF P wave is upright. In lead V1, if you look at lead V1, it's biphasic. The P wave comes towards V1, it becomes positive, and then it goes to the left side of the heart, it becomes negative. On the other hand, lead V6, AVL, it is positive because it's moving towards it. So this is just giving a 3-dimension idea. And please, you have to remember, when you look at an ECG, please, you have to think of in 3 dimension. That means if you look at lead 2, 3 AVF, that represents the inferior surface, V1, V2, V3 anterior, V4, V5, V6, and lead 1 AVL, they represent the lateral side of the heart. And so that's the kind of group thinking will be good to develop. So this is actually, again, the heart rate is fast, the rate is 138 beats per minute. So there are many ways of looking at the heart rate, and we have gone over the formula. So this is a narrow QRS tachycardia. And then I can see a P wave before each QRS complex. So you can see the P wave in lead 2, 3 AVF, and they're upright in 2, 3 AVF, and in lead 1. So that means it's a sinus rhythm, it's a sinus tachycardia. PR interval, again, 160 millisecond, QRS duration, normal, QT interval is normal. And then there is another finding, which is there is evidence of left atrial enlargement. You can see this P wave is terminal wave is deep. And then there is ST depression in lead V4, V5, V6, and lead V3, 1 AVL with T fibrillation. So my conclusion will be sinus tachycardia with ST segment depression in lateral lead. I will not make it a very dramatic, and then I'll just make a comment that consider ischemia, because please remember that I am not seeing the patient. I'm just reporting the ECG. And then you can put a comment, clinical correlation needed. And if this patient is having chest pain, the clinician will make the decision whether something needs to be done or not. This is a common ECG. Here the heart rate is 45. Again, there is a P wave before each QRS complex, and the P wave is upright in 2-3 AVF, so it's sinus bradycardia. PR interval is 158, QRS duration 98 milliseconds. So except for sinus bradycardia, it's a normal ECG. Again, what to do about it? With heart rate 45, there are many people with low heart rate. That doesn't mean that we have to do anything about it. And it all depends on the symptom of the patient. Please remember, when somebody has a heart rate of 45 and they're having dizziness, you have to make sure that that bradycardia is causing the dizziness. And the way we prove it is, let's say the heart rate now is 45 and the patient is dizzy. 2 hours later, heart rate is 45, patient is not dizzy. So that means the heart rate was not the problem. Something else is causing dizziness. So that's the way to clinically correlate. But please, so the important part is the patient is very, very important, how the patient is doing at that point. So this is another arrhythmia rhythm. This is a normal rhythm because you can see that in lead 2, heart rate is slow and then goes faster. There's a group beating and then it goes slower and then faster. And it's happening twice in 6 seconds, 12 in a minute. It's a very common finding. It's a 17-year-old female is sinus arrhythmia. This is a normal finding, nothing abnormal. As we grow older, this gets less and less because young people have higher vagal tone. So this rhythm is again a regular rhythm, and there is P wave before each QRS complex. Now this time the P wave is inverted in lead 2, 3 AVF. That means it is not sinus rhythm. And also it's inverted in lead V5 and V6, V4. So at the least I can say this is an ectopic atrial rhythm. And then if I can specify whether it's coming from the right or left side, that's good. But as long as you can say this is not sinus rhythm, this is an ectopic atrial rhythm, that's good enough. And then we have to also describe the associated finding that there is some downsloping ST segment in lead V5, V6. What is the clinical significance? We don't know. The arrhythmia by itself, the rate is fine. I mean, there are a lot. You can have this without any clinical problem at all. But this is an ECG finding. This is a left atrial rhythm because V5, V6, P is inverted. So please remember the reason I'm showing all this, that we have to look at who is creating the rhythm. Here, the P wave is creating the rhythm. In sinus, the P wave, but it is this P wave is coming from a different location in the sinus. So this is ectopic atrial rhythm. And this is, I have put the picture here, that if you see lead 2, AVF and 3, it's inverted. That means it is coming from somewhere inferiorly. And V6 is negative. That means it's moving away from V6. The only way it can move away from V6 if it is coming from the left atrium. So I've marked this focus. And if the electricity is moving away from V6, it will make a negative P wave. And that tells us that this is a left atrial rhythm. And that's the way to think in 3 dimensions. It requires a little practice. And if you keep thinking about it, you'll get it. So we will talk about a little bit about the supraventricular arrhythmias. We touched base, there are different kinds of arrhythmia. You can get sinus node reentry or sinus tachycardia. You can get AV node reentry. We can get atrioventricular reentry and tachycardia. These 2 are the most common, supraventricular tachycardia. Then, of course, we have, you see, this is an intraatrial reentry. This is ectopic atrial rhythm, the one that I showed. We can get an atrial flutter, which is a macro reentry circuit, and then atrial fibrillation. Interesting thing is that I have seen many different arrhythmias in Bangladesh, but atrial flutter is not as common. I don't know why. In the United States, we have a lot of patients with atrial flutter, but if you talk to cardiologists in Bangladesh, they see a lot of patients with atrial fibrillation, not that many with typical atrial flutter. Maybe something to do with the size of the heart or the circuit itself, but the atrial fibrillation is common. Atrial fibrillation is a very chaotic rhythm of the atrium. and we'll come to that later. So this is this one. If you look at this rhythm, the QRS is narrow, but I cannot see any P wave, and the intervals, RR intervals, are irregular. This is the key feature of this one, that if you look at this interval is longer than this is shorter, this is a little different, this is shorter, longer, and there is no pattern. And basically, this is the old description that our teachers taught us in medical school, that irregular heartbeat. And that's very typical of atrial fibrillation. And then if you look at the leads, like lead V1 or V2, you can see these fine waves, which is the fibrillation wave. A little bit coarse here, a little bit, but the key feature is the irregularity. The thing about atrial fibrillation is that it looks very irregular here, but if, now this one, you can see that it's a little bit slow here. You can see the fibrillator wave very well, but when it gets faster, you cannot see it. So, and this is the time that you can get confused. But if you look carefully, you can see that even here, there is degree of irregularity. So I'll show you another ECG, that if you look at this ECG, if we suddenly look at it, it looks regular, rate of 132. But if you carefully look at it, look at this interval is longer than this one. And this interval is longer than this one. So there is irregular pattern here, but it's suddenly, so atrial fibrillation, when it gets, so if I put the whole ECG, now you can see the irregularity is much better. So atrial fibrillation, when the rate gets a little on the faster side, it can be confused as a regular rhythm, but that's when you carefully measure with calipers. So this patient has average heart rate of 132. And of course, how to manage this patient is a different story. If the heart rate is fast, the first thing that we need to take care of is control the heart rate. And if the patient's blood pressure is good, I can give beta blockers, I can give calcium channel blocker. If the blood pressure is not, the problem with calcium channel blocker and beta blocker is that once we give them, the blood pressure will drop. And the other drug, which is not as popular as before, digoxin is a fairly good drug to use unless the patient have renal failure to control heart rate. And then, of course, the issue, one of the other issue with atrial fibrillation is risk of stroke. This is a very, very important issue. And we need to know the scoring system for risk of stroke, the CHAD-SWAS score. We can calculate it. If they have risk of stroke 2 or more, the score is 2 or more, we have to anticoagulate this patient. And there are a few drugs available. One is warfarin. The problem with warfarin is that you have to check the blood, which even in the United States is difficult. In Bangladesh, it's more problem. But now there are new drugs, the oral anticoagulant drug, which does not require blood testing, like Apixaban, which I don't think is available in Bangladesh, but rivaroxaban is available in Bangladesh, and the dose is 20 milligrams a day. So this is another rhythm. It's again a not very wide, slightly wide QRS tachycardia. It's a regular rhythm. If you look at one thing, is this just before the QRS complex, there is a P wave. And this looks like a T wave. So it is possible this is a T wave, but if you look at lead 3, it looks kind of funny. And then if I show you the whole strip, you can see here now that you see this, the flutter wave. So most of the atrial flutter conducts 2-to-1. This is a little slow flutter. Most typical flutter will have 2-to-1 conduction with a rate of 150. And if we see any narrow QRS tachycardia with a rate of 150, we must think of atrial flutter with 2-to-1 conduction. This is one patient. You see the heart rate is 154. It is very difficult to see what's going on here, but so it's a possibility that this is atrial flutter with 2-to-1 conduction or some other kind of supraventricular tachycardia. One clue can be here in this lead V2. I think there is a swap of lead V2 and V1. We see there is that 2 waves, maybe. And again, this patient, when the rate slows down, you can clearly see the flutter wave. So when I go back, it is difficult to see the flutter wave, except I can imagine that maybe there is 2 P waves here, 1, 2, So 2-to-1 conduction, but when the rate slows down, that confirms our finding that yes, this is typical atrial flutter with 2-to-1 conduction. You can stop me when I'm talking if you have anybody has any question.
Sir, already there is a question, sir.
Okay, sure. Yes, please do.
Sir, question Mahmudullah Hasaner. Sir, do you have any lab test for rivaroxaban at starting? How will we monitor rivaroxaban activity?
Oh, what is the question again?
Sir, do we have to do any lab tests for rivaroxaban at starting?
No, there is no blood test for rivaroxaban. So they are not supposed to change PT-INR, but I have seen patients with rivaroxaban where the PT-INR changes. But all these novel new anticoagulant, you don't need any blood test. Some of them require dose adjustment based on the renal function or age and the body weight of the patient, but there is no test for them to use.
So if there is severe bleeding, how can we reverse rivaroxaban activity?
That is the main problem of this drug. There are actually reversal agents available. When it came out in the United States, it was very difficult. We could not get this reversal agent. I don't know if they're available in Bangladesh. I doubt very much that they're available in Bangladesh. It is only thing is to hold them. So that is the downside of this medicine. Like if the patient is taking warfarin, you can give fresh frozen plasma, and that would have helped. But I suppose that if we don't have the reversal agent, then we can try fresh frozen plasma that may or may not work. So this is the difficult part. If somebody is on oral anticoagulation and it needs emergency surgery, that becomes a problem, especially with rivaroxaban, because that's a 24-hour medicine. We have here apixaban, which is the BID medicine. And that one, if we stop it for 12 hours, let's say somebody comes with appendicitis, and if we hold one dose after 12 hours, the surgery becomes reasonable. But rivaroxaban, you have to hold at least 24 hours to 40. Recommendation is to hold this drug for 48 hours. Thank you. Any other question?
Sir, rivaroxaban কতদিন কন্টিনিউ করা যায়? এটা লাইফ লং কন্টিনিউ করার মতো ড্রাগ বা কতদিন কন্টিনিউ করা? এই ব্যাপারে কোনো গাইডলাইন?
No, if patients have indication for anticoagulation, for atrial fibrillation, that is lifelong. For pulmonary embolism, the pulmonologists decide usually 3 to 6 months of anticoagulation. Deep vein thrombosis, same, that they will decide usually 6 months to 12 months. But for atrial fibrillation, it's a lifelong. Unfortunately, they are not officially indicated for valvular atrial fibrillation, which in Bangladesh will be majority of a lot of the cases. So that's a problem.
Thank you, sir. আপনি নেক্সট স্টেপে যেতে পারেন, কারণ স্যার এত কোশ্চেন এগুলো যদি নিতে থাকি আমার মনে হয় এখানেই শেষ হয়ে যাবে আপনার সেশন। আপনি
No, I think because this is a wrap up session, so if there are questions, I'm happy to answer.
ওকে স্যার, তাহলে আমি একটু কোশ্চেনই করি স্যার আপনাকে কিছুক্ষণ।
Sure. Yes.
Sir, Dr. Saifur Rahman's question: how do we determine ventricular rhythm?
Yes, I'm coming to that. So that question we're going to answer.
The next question. Okay, sir. Dr. Mohammad Saifullah Razin, what is the best prophylactic drug in SVT in your clinical experience, and what will be the dose of that drug?
Okay, so I'm going to come to that. So we'll come to both of these questions in a bit. Any other question related to the previous topic?
Also, how we differentiate atrial tachycardia versus atrial flutter when heart rate more?
Oh, okay. So, I mean, look at this. This rhythm, I can look at it and I can tell maybe atrial flutter with 2-to-1 conduction because there are 2 P waves I can see. Sometimes you cannot. So one of the trick would be that if I give this patient adenosine at that time, and I can block. So I'm going to come to that. So this is the patient. So this patient is a narrow QRS tachycardia. It's not narrow QRS. The QRS duration is about 120 milliseconds, but probably bundle branch block. Heart rate is 174. And this patient, I cannot see anything. So usually there are a few things we look at. We look at the position of the P wave during the tachycardia. If you can copy this slide, this will be very good. This is the esophageal electrogram to show the P wave. If the P wave is buried in the QRS complex, you cannot see it on surface ECG, and that makes AV node reentry. If there is a P wave immediately after the QRS complex, within 80 milliseconds, that's either AV node reentry or atrioventricular reentry. If it is beyond 80 milliseconds, but the RP is shorter than PR, it's most probably atrioventricular reentry. On the other hand, if it is before the QRS, that means RP is longer than PR interval, it is either sinus tachycardia or atrial tachycardia. Depending on the morphology of the P wave, it can be AVNRT or atypical AVNRT. So this is the way we look at it, if we can see the P wave. Now, if I bring to this ECG, first of all, if I look at all the leads, I cannot see much. However, in lead 3, I can see something which does not look like P wave, because it looks like something different. Now, if you challenge me, I cannot really say this is not P wave, but I think this is a P wave. And if this is a P wave, that means RP is longer than PR. And it is a biphasic P wave. And if I go back, it falls into this category. That means RP is longer than PR. So it is either atrial tachycardia or sinus tachycardia. So still, it doesn't help me because I'm just thinking. So if I give this patient adenosine, what will happen? So I gave this patient got adenosine. So look at this, what happens at adenosine. Adenosine, it develops heart block. Now you can see the P waves very clearly. And this doesn't look like flutter wave. This looks like discrete P wave. It is not sinus. So this is an atrial tachycardia. So I think adenosine can be used to help, or we can do carotid sinus massage. But one thing about carotid sinus massage is that please be careful. Please listen to the carotid arteries before you do the massage, because if there is carotid stenosis, you don't want to do it. So adenosine is helpful in distinguishing the atrial arrhythmia from other atrial flutter. So this is another one, ectopic atrial tachycardia. So I'm going to go to this narrow QRS tachycardia. So this is the narrow QRS tachycardia. And what I can see is the possibility of a P wave. So again, this P wave is immediately after QRS complex. And if you remember my earlier picture, if it is within 80 milliseconds, it's most probably AV node reentry. And this is the same patient after conversion with adenosine 6 milligram. And we studied this patient. This patient actually had AV node reentry. So this is what happens with the AV node reentry, that you have a slow pathway and a fast pathway, and you can form a reentry circuit. Usually the reentry goes down the slow pathway and come back through the fast pathway. As it comes back through the fast pathway, it goes to the atrium and goes down to the ventricle. So the P wave happens when QRS is happening, and that's why you don't see the P wave. Now the treatment of this, emergency management, adenosine. Usually you give 6 milligram, 12 milligram. Please remember, the most of the time, the reason adenosine does not work is because we have not given it very fast enough. So adenosine half-life is 9 seconds. So if I give an injection of 6 milligram of adenosine, and then I disconnect my syringe and then flush it, by that time 9 seconds is over. So what I do, I usually connect a 3-way stopcock. In one side will be saline flush, in one side will be the adenosine. I inject the adenosine and immediately inject the saline flush. And also, if possible, we elevate the arm, and that makes it effective. And then if 6 doesn't work, we give 12 milligram. Rarely we'll give 18 milligram. And then we can also give diltiazem and verapamil intravenous. The problem is they're least effective. Other problem is that because the patient already has tachycardia, and if you give verapamil, they can lower blood pressure. So that is the problem. And then electrical cardioversion can be done for this patient if they are hemodynamic unstable. Long term, what to do with this patient? Long term, if like the other day I saw a patient, she never had supraventricular tachycardia. She had first episode of SVT in July, and she was minimally symptomatic. She called the ambulance, came to the hospital, they gave adenosine, it converted back to normal rhythm. And what I did with that patient, I said, I'm not going to give you anything at all. And if this patient comes back again after 2 years, we'll give adenosine again, but there is no need to give that patient medicine. However, if she was having more symptom, I could choose beta blocker depending on the blood pressure or calcium channel blocker. These two medicines are very good, and if they control the arrhythmia, we don't have to go anything. Rarely these days we will use antiarrhythmic for SVT. So, and then of course, if calcium channel blocker, beta blocker fails, then ablation is a good choice, and it is being done in Bangladesh. It is done at NICBD, it is done at Lab 8, it is done in which used to be Apollo Hospital, and all those with a good success rate. So radiofrequency ablation is available in Bangladesh. It is effective, and if you'd ask me, radiofrequency ablation is the only curative procedure in the field of cardiology, because once you cure supraventricular tachycardia, this patient never come back. All other kind of treatment that we do in cardiology is not curing it. Like if somebody has coronary disease, we put a stent in, we are not curing it. It can come back again. But once you do ablation of supraventricular tachycardia, these patients will never come back to see the physicians because it's cured. So the question was the ventricular, there was a diagnosis of ventricular arrhythmia. How to diagnose? So this is a patient with a wide QRS tachycardia with a heart rate of 200 beats per minute. This patient has a history of cardiomyopathy, and the question is, what is this? This can be ventricular tachycardia, or it can be supraventricular tachycardia with pre-existing bundle branch block. And this patient, when we rate slowed down, the morphology of the P wave is exactly the same as this one, and you can see the flutter wave. So this was actually a supraventricular tachycardia, atypical atrial flutter with one-to-one conduction. But if I saw this ECG, and if I had no other history, except that patient have history of cardiomyopathy, I have to consider this patient as ventricular tachycardia. Here, I have the benefit of this. So this can be confusing, but there are some algorithms that we can use. Now, this patient, again, has a wide QRS tachycardia, and it can be either ventricular tachycardia, sinus tachycardia with right bundle, SVT with right bundle, or atrial flutter. The rate is 219 beats per minute. Sinus tachycardia is unlikely. So it is either SVT or ventricular tachycardia. The good news is that I had an old ECG of this patient. And you can see that in V1, we have right bundle, right pattern. And if I go back, same pattern. So if I have an old ECG and wide QRS tachycardia, it makes our life very easy to treat this patient. I can give this patient adenosine and we'll be fine. How about this one? This one, the rate is around 200 beats per minute, a little bit over 200 beats per minute, and it's wide QRS tachycardia. So is it VT or SVT? So that's the question. Now, one feature that we use it, look at this, V1 is positive, V2 is positive, V3 is positive, V4 positive, V5, V6. All of them are positive, and we call that concordance. So in precordial lead, if all the QRS looks in one direction without any RS pattern, that's most likely ventricular tachycardia. So if precordial concordance present, it is ventricular tachycardia. If there is no precordial concordance, like this one, if you look at this, it doesn't have precordial concordance. That means this side is looking down, this side is looking up. Then we look at some other feature. So we look at one of the features is that from onset of R wave to the nadir of the S wave, more than 100 milliseconds in any precordial lead. Look at this one. We're looking, what I'm talking about, we're looking from the beginning of the QRS complex in any precordial to the deepest point of S wave. Is it more than 100 milliseconds? So yes, look at, I have expanded the V4, and it starts from here, it finishes here. It's 130 milliseconds. So this is a white QRS tachycardia, looks like left bundle, but in any chest lead, if from the beginning of the R to the deepest point is more than 100 milliseconds, that suggests VT. So this is most likely VT. How about this one? So this one now it's kind of right bundle morphology, but white QRS tachycardia. So what I look at is that any AV dissociation. That is another feature. So here you can see that if you look at rhythm strip here, there is a P wave here. How do I know this is a P wave? Because it's not here, present here. And if we go backward, I can see another one over here. And then I can see another one. So with a long rhythm strip, I can see all this P wave marching through. And there is a possible P wave here because there is a dent on the T wave. And then there is another P wave. So this ECG showed actually an AV dissociation. But so this is the ventricular tachycardia. This is very, very diagnostic. This is actually ECG from Bangladesh. This is interesting that this is very common in Bangladesh. This ventricular tachycardia is fascicular ventricular tachycardia. It's very common in Bangladesh, not many in the United States. In Southeast Asia, we have a lot. And Dr. Mohsin Hussain at NICVD has done ablation on these patients, more than 70 of these patients, and they are cured permanently. So if there is AV dissociation, that's ventricular tachycardia. And then we also look at here, you can see the P wave. And there is this bit is interesting. If you look at this one, is Y, this is the VT beat. But this looks in between a sinus beat and the VT beat. We call those as fusion beat. So AV dissociation, presence of AV dissociation or presence of fusion beat or capture beat during the tachycardia makes it ventricular tachycardia. Now, this is easy. This is a slow ventricular tachycardia. That's why it's easy to see. But it's very difficult in fast ventricular tachycardia. So how about this one? This one, again, apparently looks narrow. If you look at LBBB, suddenly it may look narrow, but it's not. The QRS duration is about 160 milliseconds. So we can use morphology criteria. And the morphology criteria is this. If you look in right bundle type, if there is any of this pattern, lead V1 just positive, QR pattern, or RS pattern. In V6, only Q or QR, or RS with less than, ratio is less than 1. And this one, if you look at, this is actually a right bundle pattern, and in lead V1, there is QR pattern. And also fulfills the other criteria that we described before, that from the beginning of QRS to the deepest point, it's 110 milliseconds. That means it's more than 100 milliseconds. So there are two criteria. It fulfills the morphology criteria of VT. It fulfills the QRS, this duration criteria of the R wave to the S wave. So this is ventricular tachycardia. And actually, this patient had AV dissociation also, which is very difficult to see in this ECG. So if we go back and use this, this is again a white QRS tachycardia. We have to entertain all the possibilities: sinus tachycardia with bundle branch block, ventricular tachycardia, atrial flutter with left bundle, sinus tachycardia with the possibility of hyperkalemia because it's a white QRS. But this is not hyperkalemia. This is actually, again, if you look at one of the criteria in lead V2, the initial R wave in lead V2, if it is more than 30 milliseconds, that's VT. And this patient had that, plus it has the second criteria of this beginning of the R wave to deepest point of S wave with more than 130 milliseconds. So these are the, so if there's morphology criteria, then it's VT. If none of this fulfilled, then it's not. Like this one, actually, this one is the patient with SVT with left bundle aberration because the initial R is narrow. It doesn't fulfill any of these criteria. If you look at beginning of the R wave, beginning of the deepest point of S wave, it's about 80 milliseconds. And I cannot say AV dissociation, so that's VT. So this is SVT. So whoever asked the question, does he have any question on this?
স্যার আমাদের কাছে স্যার অনেক কোশ্চেন চলে আসছে স্যার, আমি আরো দুই একটা কোশ্চেন করব স্যার।
অবশ্যই অবশ্যই।
Sir, another question, Dr. Jerin Shamid, respected sir, in hemodynamically stable non-valvular atrial fibrillation, should we do early rhythm control or wait for spontaneous rhythm control? If so, what is the strategy, chemical or electrical?
Okay, so the question is, so let's say there is a patient who is 55-year-old female comes to the hospital with palpitation, which started about 24 hours ago, and patient is now in atrial fibrillation. Majority of these patients will convert spontaneously to sinus. More than 50% will convert spontaneously to sinus rhythm. That's the natural history of this disease. And then rest of them will not. And in those cases, we need to do rate control with beta blocker, calcium channel blocker, or digoxin, and also make a decision regarding anticoagulation. Chemical cardioversion. Of course, there is a tendency to use amiodarone a lot. We used to use amiodarone. We don't use it that much anymore. What we do, because amiodarone is such a toxic drug. So if it is first time atrial fibrillation and patient does not convert to sinus rhythm, we can anticoagulate the patient for 4 weeks and do electrical cardioversion. And if after electrical, it may remain normal for many, many years after electrical. If I find that I send the patient home and the patient comes back to me after 2 years again with that, I can again do cardioversion. I don't have to use medicine for 2 years to prevent one attack. However, if this patient comes back within, let's say, 2 months with atrial fibrillation, then we have to decide on antiarrhythmic medication. And if the choices are class 1C antiarrhythmic, in Bangladesh we have propofenone available, or we can use class 3 antiarrhythmic, which is sotalol, and of course the last choice will be amiodarone. Amiodarone nowadays we do not try to give it to young people. Okay.
Okay, sir.
Does she have any other question?
Sir, অনেক কোশ্চেন আছে স্যার। ডক্টর সাইদুর রহমানের একটা কোশ্চেন আছে, এভি ডিসোসিয়েশন, ক্যাপচার বিট, ফিউশন বিট সম্পর্কে যদি স্যার একটু বলেন।
Okay. Now, AV dissociation, the term means the ventricle and the atrium, they are beating independent of each other. Now, the perfect example of AV dissociation actually is complete heart block. If somebody is in complete heart block, you get AV dissociation. But in ventricular tachycardia, what happens? That the ventricle is beating independent of the sinus beat, and we get AV dissociation. So I'm going to come back to this. Sorry, I'm going in the wrong direction. So this is ECG. The question was, it is a white QRS tachycardia, and I was looking for AV dissociation. So I looked. You cannot look at every lead everywhere, so you look at a long rhythm stream. So if I look at this, if you look at the beginning of the QRS, there is nothing before this, nothing before this. But before this QRS complex, there is something. And I'm saying maybe this is P wave. Or it can be an artifact. If it is an artifact, it will not come back again. So there is no P wave here, there is no P wave here, there is no P wave. Again, I can see something. And now I can tell this is coming back again and again, but this P and QRS has no relation. So they are dissociated from each other. So that's AV dissociation. Now, fusion bit and capture bit. I don't have an example of capture bit, but if you look at this one, here there is a P wave, and there is no P wave, no P wave here. And then look at, remember this QRS complex, this QRS complex. There's a P wave, and this QRS complex is a little different from the one before. So what probably has happened that this P wave is conducting into the ventricle. At the same time, ventricular tachycardia, there is a beat, they fuse together and produce a complex which is in between the two. And that's a fusion beat. And it would have been captured beat if the morphology is totally compared like the normal beat. I don't have a ECG of this patient normal QRS, so I don't know what it looks like. But this looks most likely to be a fusion beat. Thank you. Any other questions?
Next question, sir, Dr. Tohid Hanifir, sir. Sir, our question is, sir, will you please again explain morphology criteria for VT?
Yep. Okay. So morphology criteria, what happens is that let's say this is a tachycardia. And this is a wide QRS tachycardia. And if I look at V1, it suddenly looks like a right bundle type. And I have gone through this. This one does not show concordance. This one, I cannot see any clear-cut AV dissociation. So the question is, what is this? So one of the criteria that I can use is morphology criteria. This at the morphology. If the QRS complex is of right bundle type, we look at this feature. In lead V1, QR pattern, RS pattern, or typical R, monophasic R wave. In V6, QS pattern, RS pattern, or QR pattern, one of these. So let's look at this one. So this is a right bundle type because it's positive in V1. And this one, see, it's a QR pattern. That means it falls into this criteria. And also, another thing that it fulfills is beginning of QRS to the deepest point of S wave more than 100 milliseconds. We discussed that before. So that criteria also fulfills that. If it was left bundle type, then you use this criteria. That means the initial R wave in lead V1 more than 30 milliseconds. In V1, R to S more than 60 milliseconds, or if there is a hump. And then in V5, V6, QR or QS pattern. And so let's look at this one. I have one which is this one. This one is, there is initial R in lead V2, which is wide. And look at this, how wide this is. This is basically 1.5 box. If you look at, remember, left bundle branch box, the initial R in V1, V2 is very narrow, less than 30 milliseconds. This is almost 60, 70 milliseconds, 70 milliseconds. And if it is more than 30 milliseconds, that's VT. So that's one feature. Second other feature that it has, it also has the other feature that from the beginning of the R wave to the deepest point of S wave, it is 30 milliseconds in lead V4. I have just expanded this channel. So these are the criteria that you use. And do you remember it all the time? You keep doing it. And the way I do it is, you can just write these features down in an iPhone. And every time you see an ECG, just use the algorithm to see it fulfilled. Please remember that not all the features will be fulfilled by single ECG. If we find one or two, that is most likely VT. Thank you.
Thank you, sir.
Anything else?
Sir, question to sir অনেক আছে।
স্যার আসসালামু আলাইকুম
Yes.
স্যার আমি একটা কোশ্চেন করতে পারি স্যার?
Sure, definitely.
স্যার আমি একটু গার্বোজা ক্রাইটেরিয়া যে আছে এলবিবিবির গার্বোজা
Yes.
ক্রাইটেরিয়াটা একটু জানতে চাচ্ছিলাম, একটু যদি বলতেন।
Well, let me see. That's a different lecture. Give me, I'll stop sharing here and see if I can pull up that. I hope I have it. So the problem is that if you look at left bundle branch block has some ST elevation inherent. And so when people have acute myocardial infarction, there is ST elevation. So how do you know this ST elevation is not from just normal left bundle branch block ST elevation or acute ischemia? Yeah, I had ECG on that. Okay. So this, if you look at this ECG, this is left bundle. You understand that, right? Are you with me?
Sir, screen share hoyni, sir.
Oh my gosh. So let me see. Share screen. Okay, can you see the screen now?
Yes, sir.
Okay, who was asking the question?
Kanta, sir.
Kanta. Okay,
Yes, sir.
so you understand this lead V1, lead 1 looks like left bundle, right? You understand that?
Yes,
Kanta?
sir.
Yes.
Ji.
So now look at lead V1 and V2. This patient is in the hospital with chest pain, and there is ST elevation in lead V2 and V3. Now this, how do I know this is ischemia, not just left bundle pattern? And so they developed this criteria that if you have ST elevation more than 1 millimeter or more concordant with QRS complex. What I mean that if the QRS is upright and there is ST elevation 1 millimeter or more, it's positive. If ST elevation 5 millimeter or more discordant with QRS, that means QRS is negative, ST is more than 5 millimeter. And here, if you look at this ST elevation, here is 3 millimeter and then 7 millimeter ST elevation in lead V2. And that is the criteria that is used for. And then you can also use ST depression. ST depression 1 millimeter, one V1, V2, V3. We don't have that in this. In this one, what I have is 5 millimeter or more ST elevation in discordant QRS. You understand the term discordant, right?
Yes, sir.
Yeah, that means it is opposite of QRS. So here, QRS is negative, ST elevation is 7 millimeter. And also here, there is 1 millimeter ST elevation where it is ST elevation 1 millimeter or more concordant with QRS. It V4. QRS is upright, ST elevation is about 4 millimeter. And here is 1 millimeter, anything more than 1 millimeter. And that's the criteria that is used for left bundle branch block. But be careful.
Thank you, sir.
Yeah, be careful. Now, if this patient is not having chest pain, so let's say this patient comes to the hospital with some leg pain, gangrenous toe, and you do ECG and you find that will be a problem then. It is unlikely that you will find this kind of ST elevation, but you can see changes which is due to level. So this is the criteria that is used for acute MI in left bundle. Okay. Any other question?
Thank you very much, sir.
Sure. As an anybody else?
Yes, sir. Yes, sir. I'm taking the question. Sir, from Dr. Kamal Parvez, respected sir, if with first ventricular rate, patient is on shock, how to manage the patients?
Patient is?
Wait, sir. Sir, question, respected sir, if with first ventricular rate, patient
Yes.
is on shock, how to manage the patients?
Okay. So basically now we are talking about a patient who is hemodynamically unstable and with bundle branch block. So when you see that, at that point, it can be either atrial fibrillation or ventricular tachycardia. And if the patient is hemodynamically unstable, you have to do electrical cardioversion. There is no other choice because you cannot give any medicine and wait for this to to get better. Anybody else?
Yes, sir. I'm asking next question, sir.
Yes.
From Dr. Saifur Rahman, sometimes it is difficult to differentiate atrial tachycardia and atrial flutter. Please enlighten.
Yes, we talked about that. I mean, it is true that it is very difficult to determine the difference. And then maneuvers that we use. First of all, if I can see any P wave, look at the morphology of the P wave, number one. Number two, we can give adenosine. And once we give adenosine, you can see the atrial flutter or the atrial tachycardia. But the problem is, sometimes is the question of semantics. If you have a usually atrial tachycardia rate, we consider 150, 160, and the flutter rate is much faster, like 180 or 200 or over that. And the flutter wave morphology, but sometimes atypical flutter can look like atrial tachycardia. So one is the rate cutoff, second is the morphology of the P wave. These are the two features that we use to distinguish these two entities.
Thank you, sir. Dr. Kamal Parvez, do you want to ask live?
Assalamu alaikum, sir. Assalamu alaikum, sir. আমি ডাক্তার কামাল পারভেজ, আমি টুয়েলভে রেসিডেন্সি কোর্সে আছি মেডিসিনে। আমার একটা প্রশ্ন হলো যে কার্ডিওলজি আউটপেশেন্টে আমি গত সপ্তাহে একটা রোগী দেখেছি, 42 ইয়ার ফিমেল ডায়াবেটিক পেশেন্ট। তার 1 বছর আগে আনস্টেবল এনজাইনা নিয়ে ভর্তি ছিল এবং তার তখন এনজিওগ্রাম করে নরমাল করোনারি এপিকার্ডিয়াল আর্টারি পাওয়া গেছে। তো 1 বছর পর সে আসছে আবার চেস্ট পেইন নিয়ে এবং ইসিজিতে এলবিবিবি পাওয়া গেল, ট্রোপোনিন আইও নরমাল এবং ইকো নরমাল। এই ক্ষেত্রে রোগীর করণীয় কি? বা এর আগেও একটা পেশেন্ট পেয়েছি যে 50 ইয়ার হাইপারটেনসিভ পেশেন্ট, চেস্ট পেইন নিয়ে এসেছে, ইসিজিতে এলবিবিবি, ট্রোপোনিন আই নেগেটিভ এবং ইকো নরমাল। পরের স্টেপ ম্যানেজমেন্টে কি হবে?
Well, I mean, your first patient had a normal angiogram 1 year ago, number one.
Yes,
Number two, this time comes with chest pain and troponin is negative. Echo doesn't show any regional wall motion abnormality except whatever associated. So you don't have to do anything. I mean, people can have pain from many different causes. I mean, over here, we'll probably do a nuclear stress test. And if nuclear, just to reassure the patient, I doubt very much that and the patient's age is young, had normal coronary, so it is unlikely that it's ischemic origin. And I probably will do a nuclear stress test to see if there is any local ischemia anywhere. And remember, nuclear stress test Bangladesh এখন হয়, এবং BSMMU does nuclear stress test. It's interesting that a lot of the tests that are done in Bangladesh, I know them, but a lot of physicians in Bangladesh do not know that these are done here locally. It's kind of sad that situation, because we have to make sure that we know what is available. And the quality of this stress test in BSMMU is very good. I have seen the pictures. Their quality is good. It's a good test to use.
Okay, sir. Last question, sir.
Sure.
Sir, Dr. Saifullah Rajan's question, respected sir, what is the dose of calcium channel blocker in SVT prophylaxis? Is there any change of hypertension, getting AC inhibitors for hypertension of that patient at prophylactic dose of CCB?
Okay, so the question is, what is the dose of calcium channel blocker? If the patients don't have hypertension, we cannot start higher dose. So I usually start, we have long-acting diltiazem. The lowest dose you can use is 120 milligrams a day, and then 180. It becomes easier if these patients have actually hypertension. then we can use 240 milligrams a day or 360 up to, I've gone up to 360 milligrams a day. But the limiting factor is the blood pressure. Thank you.
Thank you, sir. Sir, আপনি কি স্যার আর কোনো মানে কিছু প্রেজেন্ট করবেন স্যার? মানে
No, I think we should stop here. And as we discussed, that I will be happy to, if there is a group who wants to report ECGs, I can send them ECGs, and they will report it like the way we expect to report, and send it to me, and then I can send comment back. I can do about 20 in a group. If you choose to find that, a group of 20 physicians who want to report ECGs, we can do it for a period of like 4 to 6 weeks. And each time I'll send 5 ECGs to the group, and the group will respond to me individually so that the others will not know what he is reporting.
ওকে স্যার, দেন আমাদের যারা রেগুলার যারা অ্যাটেন্ড করছে স্যার এতদিন সেশনগুলা, আমরা স্যার আমি স্যার ওদের সাথে একটু মানে একটা মেসেঞ্জার গ্রুপ করে ফেসবুকে তাদের সাথে স্যার কমিউনিকেট করে আমি আপনাকে স্যার মেইলে জানাবো স্যার।
Sure. And thank you for inviting me for doing this. And I'll be happy to do it again if we start to do again another session sometime in future.
না স্যার, আমরা স্যার ফিউচারে স্যার আপনার কাছ থেকে যদি কোনো আপনি আপনার সাথে আমাদের কন্টিনিউশন ইনশাল্লাহ থাকবে, কিন্তু আপনি যদি স্যার নেক্সটে আমাদের কোনো ট্রেনিং সেশন বা কিছু করান স্যার, আমরা এখান থেকে তাহলে 40-50 জন নিয়ে স্যার আমরা 1-to-1 আপনার সঙ্গে স্যার কমিউনিকেট করে ওই গ্রুপটা আপনি স্যার ডিরেক্টলি কমিউনিকেট করে যদি স্যার কোনো মানে হয়তো ওইখানে স্যার আমরা একটা সিলেক্টেড পার্টিসিপেন্ট নিব 30 থেকে 40 জন, আমরা স্যার ডিরেক্টলি যাতে আপনি 1-to-1 কমিউনিকেট করতে পারেন স্যার, এইভাবে যদি স্যার কিছু অ্যারেঞ্জ করা যায়।
ওকে, শিওর, উইল ডু দ্যাট।
স্যার আমাদের সাথে মানে প্রফেসর মাহমুদ হাসান স্যারও আছেন। প্রফেসর মাহমুদ হাসান স্যার কি আছেন আমাদের সাথে?
জি
হ্যাঁ আছি, জি
স্যার। তাহলে আমরা রফিক স্যারের কনক্লুশন রিমার্ক নিয়ে তারপর আপনি সেশনটা ক্লোজ করবেন।
হ্যাঁ বলো। ডেফিনেটলি
স্যার অবশ্য কনক্লুড করে ফেলছেন, তারপরও স্যার আপনি আপনার কনক্লুশনে যদি স্যার কিছু বলেন।
মাহমুদ ভাই।
জি না, আপনাকে কিছু আরো যদি বলতে চান তাহলে বলার জন্য আমরা অনুরোধ করছি।
No, it was a pleasure doing it, and I think this is a good forum. I think one of the things COVID has done is this. One of the benefit of COVID has been Zoom technology and use of remote teaching. And I think this is effective because what's happening these days that the physicians are busy, and it is like I can teach multiple residents in different hospitals. It doesn't matter where I am. I can be in my office. I can be in a different location. So this has been good, especially some of the topics like ECG, investigations, lectures. But also please remember, I have to remind our audience that the patient is the primary thing and you have to see patients. It doesn't matter. আমাদের একজন মন্ত্রী আছেন, এখন উনি বেঁচে আছেন, ছিলেন আমাদের যোগাযোগ মন্ত্রী। উনি একটা কথা বলছিল যে গাড়ি চালাইতে গেলে পড়াশোনার কি দরকার, এবং এটা নিয়ে সবাই খুব হাসাহাসি করছিল একটু, কিন্তু হি হ্যাজ এ ভ্যালিড পয়েন্ট। সে ভ্যালিড পয়েন্টটা হলো যে if somebody has a PhD in driving and never has driven a car, on the other hand there is somebody who has no education can drive a car, or somebody who has a PhD in driving and can drive a car. Whose car are you going to get into? Probably the PhD who can drive. If the PhD who cannot drive, if there is comparison between a PhD in driving without any driving experience versus somebody who has never driven it versus somebody who has no education but can drive a car, you will get into the car of that person. So I think this is relevant to medicine also, that we have to take care of patients. You have to take care of patients, you have to see patients and learn from it. And the other thing is that it's a continuous learning process. I mean, Mahmoud Bhai I think he still studies a lot. We all study and we cannot stop studying. So please continue studying and keeping your knowledge up to date. Thank you.
Thank you, sir. আমরা এটাও আশা করব আপনি তো স্যার ট্রেনিং সেশন কন্টিনিউ করবেনই। আপনি যদি স্যার ইসিজির উপরে কোনো লেকচার নোটস বা লেকচার সিরিজ, যেমন মাহমুদ হাসান স্যারের কিন্তু আমরা খুব শীঘ্রই ইরিটেবল বাউল সিনড্রোম এবং ইনফ্ল্যামেটরি বাউল সিনড্রোমের উপরে বুকলেট সারা বাংলাদেশে স্যার দিয়ে দিব। আমাদের টার্গেট অ্যারাউন্ড 10,000 কপি পুরো বাংলাদেশে স্যার আমরা ফ্রিতে দিব। এবং আপনি যদি স্যার এরকম কিছু আমাদেরকে রেডি করে দিতে পারেন স্যার, হয়তো ইসিজি খুব সিম্পলতে আমরা এটা হয়তো স্যার পুরো যারা আগ্রহী ডিস্ট্রিবিউট করতে পারবো স্যার। আর স্যার আপনাকে আসলে থ্যাঙ্কস দিলে ছোট করা হবে, কারণ আপনার সাথে আমার কথা ছিল স্যার 5টা সেশন আমরা করব, কিন্তু অলরেডি 8টা করে ফেলেছি। আর যারা স্যারকে যারা মানে দোজ হু উইল মিস স্যারস ক্লাস, স্যার কিন্তু প্রতি শনিবার দিন ইসিজি স্টাডি গ্রুপ সাথে ইনভলভ আছেন এবং আমাদের গ্রুপে কিন্তু আমরা একটা দেই। আপনারা চাইলে স্যারের সেশনগুলো জয়েন করতে পারবেন এবং আমরা আশা করি খুব শীঘ্রই স্যার আমাদের সাথে কমিউনিকেট করে হয়তো নেক্সট প্ল্যান স্যার আমাদের সাথে করবেন। আমি স্যার মানে অলরেডি স্যার মেসেজ বক্সে স্যার সবাই আপনাকে থ্যাঙ্কস দিয়েই যাচ্ছে, আমি স্যার আর ইলাবোরেট করছি না। আমি স্যার সেশনটি কনক্লুড করার জন্য মাহমুদ হাসান স্যারকে আহ্বান জানাচ্ছি। আর রফিক আহমেদ স্যারকে থ্যাঙ্কস এগেইন ফর ইওর লাভ এন্ড কেয়ার।
অনেক ধন্যবাদ আমাকে আবার সুযোগ দেওয়ার জন্য এহসানুজ্জামান সাহেব। আমি 3টা কথা বলবো। প্রথম কথাটা হলো যে বাংলাদেশে এবং সারা পৃথিবীতেই এখন কোভিড-19 অত্যন্ত হ্যাবক সৃষ্টি করেছে। যদিও আমি বলবো যে আমরা একটু ফরচুনেট যে অনেক দেশে যত ব্যাপক আকারে হয়েছে বাংলাদেশে অতটা ব্যাপক আকারে হয় নাই, কিন্তু আমাদের হেলথ প্রফেশন মেডিকেল প্রফেশনাল বিশেষত ডাক্তাররা এবং নার্সরা দে আর আন্ডার এ গ্রেট ডিল অফ স্ট্রেস। এই ব্যাপারে আমরা যদি না বলি তাহলে অন্যায় করা হবে। যে আপনার এখানে তো সিচুয়েশন ওয়েস্টার্ন কান্ট্রির চাইতেও আমরা অনেক বলা যেতে পারে যে অনেক বিপজ্জনক সিচুয়েশনের মধ্যে কাজ করছি। যে আপনার রোগীদের আইডেন্টিফিকেশন নাই যে কার রোগ আছে বা নাই, অনেক সময় রোগী হাইড করে আসছে এবং প্রপার প্রোটেক্টিভ ইকুইপমেন্টও আমরা সবসময় পাচ্ছি না। অনেক ডাক্তার আক্রান্ত হয়েছেন, অনেকে জীবন দিয়ে দিচ্ছেন। তো এই সময়ে এই যে অত্যন্ত স্ট্রেসফুল সিচুয়েশনের মধ্যে অনেকের কিন্তু বার্ন আউট হয়ে গেছে। মানে আপনার কি বলা যায়, মানে বার্ন আউটের নিয়ে আলোচনা করতে চাচ্ছি না, কিন্তু মানে অনেকেই ভেঙে পড়েছেন আর কি। তো এই পরিস্থিতিতে যারা শিখতে চেয়েছেন আমি তাদেরকে অত্যন্ত সাধুবাদ জানাই যে আপনারা এই পরিস্থিতির মধ্যেও কাজ করে আপনারা শিখতে চাচ্ছেন। এটা একটা কথা। দ্বিতীয় যে কথাটা বলতে চাচ্ছি যে দেখুন, হার্ট একটা ইম্পর্টেন্ট অর্গান। মানে আপনার ডেথে আপনি দেখেন যে এটা বড় ইম্পর্টেন্ট কজ অফ ডেথ হচ্ছে আপনার হার্টের ডিসফাংশন। তো আর চিকিৎসাও বেশ স্পেশালাইজ হয়ে গেছে, এটা আমি আগেই বলেছি। কিন্তু ইসিজি এমন একটা জিনিস যে বাংলাদেশের অনেক জায়গায় এখন চলে গেছে। এটা আপনি তুলনা করলে আশ্চর্য হবেন যে 1965-66-এ আমি যখন 3rd ইয়ার 4th ইয়ারের ছাত্র ছিলাম তখন আমাদের মেডিকেল কলেজে একটা ইসিজি মেশিন ছিল, এটা আবার তালা বন্ধ থাকতো প্রফেসর সাহেবের রুমে, মাঝে মাঝে বের করে আমাদের দেখাইতো। আমি বোধহয় সারা ছাত্র জীবনে 2-3বার এই মেশিনটা দেখেছি। সেই জায়গায় এখন আপনার সারা বাংলাদেশে অনেক ইসিজি মেশিন হয়ে গেছে, ইসিজি ট্রেসিং হচ্ছে। এখান থেকে আপনারা তো জানলেন যে অনেক রোগ ডায়াগনোসিস করা যায়, অনেক চিকিৎসার লাইন ঠিক করা যায়, এবং এইটাই রফিক সাহেব আমাদেরকে শিখিয়েছেন। তো আমি মনে করি যে রফিক সাহেব যে এই সময়টা তার মূল্যবান সময় আমাদেরকে দিয়েছেন এবং উনি তার মূল্যবান সময় উনি নিজ খরচে বাংলাদেশে এসে বাংলাদেশে এই যে ইলেকট্রোফিজিওলজি সার্ভিস উনি নিজে তৈরি করে গেছেন, এবং এখন যারা যারা ইলেকট্রোফিজিওলজি বাংলাদেশে করছে তারা কিন্তু সবাই ওনার কাছেই ট্রেনিং নিয়েছে এবং উনি ইনিশিয়াল যন্ত্রগুলো উনিই দিয়েছিলেন। তো এই যে উপকারগুলো উনি বাংলাদেশে করেছেন এই জন্য আমরা খুবই কৃতজ্ঞ থাকব এবং এই সেশনটার জন্য আরো বিশেষভাবে কৃতজ্ঞ, এবং আমি আশা করি ভবিষ্যতে উনি আমাদেরকে আরো এইরকম ভাবে সমৃদ্ধ করবেন। তো আমি রফিক আহমদ সাহেবকে আবার ধন্যবাদ জানাচ্ছি এবং বিডি ফিজিশিয়ানস এহসানুজ্জামান খান সাহেব ধন্যবাদ জানাচ্ছি, এবং যারা পার্টিসিপেট করলেন তাদেরকে আমি আবার সাধুবাদ এবং অভিনন্দন জানাচ্ছি যে আপনারা এই কঠিন সময়ের মধ্যেও আপনারা শিখতে চাচ্ছেন, শিখতে চেয়েছেন এবং শিখেছেন। অনেক ধন্যবাদ। সবাই ভালো থাকুন। আসসালামু আলাইকুম।